this computer. All right, so we'll start the lecture today on the content for the last session of cardiovascular system or diseases under the cardiovascular system. And the first disease we will cover is the disorders of the pericardium. And I have, this is one of the good figures or pictures to, provide with the, like anatomy and anatomy of the and the layers of the myocardium. So with the inner, lining or wall of the myocardium is the endocardium, and then the muscle, which is the myocardium, and then we have the outer aspect or layer will be the pericardium, that we have more than one pericardium. The first one from the outside called fibrous, and then next to that is the serous pericardium, and then we have the serous pericardium visceral. So we have parietal and visceral. Between the parietal and the visceral, we have fluid, pericardial fluid, small amount of fluid between these, the parietal and the serous. So and then another layer, which is the same layer here is called also epicardium, which is the serous pericardial visceral layer is called endocardium, because this one also, there is a disease that involves this layer called endocarditis. So that will be the infection of this layer, endocarditis. And I'm sorry, I said endo, no, it's epicardium. This is the endocardium and this is the epicardium. So the epicarditis will be this, and the endocarditis will be the inner one, the very inner layer inside. Then the myocardium, and then the pericardium, the serous visceral, and then the parietal. Between the parietal and the serous, we have small amount of fluid, and then the outer one, all, the outside or the outer one would be the fibrous pericardium. So very thin layers, as you see here, is like a sheath pericardium, like a thin, very thin sheath that covers the heart. So the first disease is called the pericardial disease, which is it's the inflammation of the pericardium, but the disease can be acute or chronic. When it's chronic pericarditis, it's becomes constrictive. So the constrictive pericarditis is the chronic type. And then either one, which is either acute or chronic, if that results, so it will lead to something called cardiac tamponade or tamponade. Tamponade, which is the pericardial effusion. Acute pericarditis, or the chronic one, the constrictive one, can result in fluid to be collected, not the normal small, tiny, amount of fluid, but it will result in increased amount of fluid to be secreted, and that will result in the cardiac tamponade due to that inflammation and the acute or chronic pericarditis. So acute or chronic can lead to pericardial effusion, or what is called the cardiac tamponade. Now, the risk factors for that, it can result from either infections or non-infectious causes or factors. The infections like viral viruses or bacteria or fungal toxoplasmosis, also Lyme disease. The non-infectious factors would include like kidney problems, like patients with end-stage renal disease. They tend to develop a complication, and this is one of them, the pericarditis. So one of the long-term complications of the end-stage renal disease is pericarditis or pericardial effusion later on. Other conditions that may lead to or cause this disease, or as an etiology, will be like acute myocardial infarction, MI, lung or breast cancer, lymphoma, leukemia, rheumatoid arthritis, patients who receive radiation treatment for cancer, they tend to develop, this type of problem as a complication from the treatments. Now, the disease itself is believed to be an autoimmune disease, which could also result from last week we discussed something called Dressler syndrome. The Dressler syndrome, or post-MI syndrome, which is the complication from the acute MI. Patients tend to develop the Dressler syndrome or post-MI response, which is it's an believed to be an autoimmune response. So this disease also could result in response to the Dressler syndrome post-acute MI, or rheumatic fever, or rheumatoid arthritis, or lupus, SLE, systemic lupus erythematosus, SLE. There is an acronym, mnemonic that you can remember to remember all the factors or causes or etiological factors for the pericardial disease, pericarditis, which is cardiac rinds. And that's the mnemonic to remember all the factors or etiologies and causes for the disease. So before we go to the cardiomyopathy, just briefly, I want to give you some key points especially about the presentation of the patient with pericarditis. The patient will have a sharp pleurisy, and you can refer to the physical, assessment course, and you find the pleurisy, right, as the patient will experience the chest pain during the inhalation. Sharp pleurisy, chest pain during the inhalation, because of the wrapping of these thin layers that we just described earlier against each other, and that will result in the pleurisy. So that's in addition to the dyspnea and cough and fever that is known with, to be presented or be, occur in patients with this disease. So the chest pain tend to be also worse in the supine position, when they are in the supine position, and when during the inspiration, when they take their breath, they experience the chest pain, and that's from the pleurisy. That's something just to keep in mind, just about to remember as a significant manifestation, or as we take the patient history or physical exam finding, you'll find that the patient will have this experience, or in terms of the chest pain during the inhalation, which is one of the key manifestations of the disease. In addition to changes in the, will be revealed from the chest X-ray, and also from the EKG or ECG, and the changes in the EKG, especially the ST wave elevation. And we'll go over the dysrhythmia today and give you just the basics of the dysrhythmia. The cardiac tamponade also will be discussed. So all of these diseases will be covered in adult health, either 2 or 3, and we're going to build on the pathophysiology, what we learned today from the cardiovascular disease in adult health 2 and 3, when we covered that, respective, disease, we're going to cover the diagnostic studies and the treatment and the nursing care and the management, and all of these plan of care for the patient will be covered in adult and mid-surg courses. So the cardiac tamponade is one of them also important, which is, we said it's pericardial effusion, which could result from the acute or chronic pericarditis. And it's the excessive, or fluid excess or large amount of fluid in the pericardial sac that will increase the intrapericardial pressure. So the presence of a large amount of fluid around the heart is going to restrict the heart from contracting and from doing the or performing the contraction, which will compromise the ventricular filling, and that will eventually result in decreased cardiac output. So remember that the cardiac tamponade is the fluid around the heart that is going to increase the intrapericardial pressure. It will lead to compromising the ventricular filling, and that eventually is going to result in decreasing the cardiac output. So that's from the fluid that is collected around the heart. Cardiac tamponade, that is the description and the disease process of what is called cardiac tamponade or pericardial effusion. And that cardiac tamponade or pericardial effusion, again, it could result from the pericarditis, acute or the chronic type. Also may result from other conditions like post-open heart surgery or from trauma, like stab wound to the chest, systemic lupus disease, TB, tuberculosis, malignant disease, cancer, like lung cancer, for example, or any type of cancer, especially just in malignant, disease in general that can result in pericarditis and then to the cardiac tamponade. So next disease is cardiomyopathy. So cardiomyopathy, which is it's a more than one disease. It's a heterogeneous group of diseases of the myocardium. So this disease affects the myocardium, not the endocardium, not the epicardium, the pericardium. It's the myocardium, that is the cardiac muscle itself. So the cardiac muscle, the myocardium, will be affected by this disease, and it's a heterogeneous group of diseases of the myocardium, and it's associated with mechanical and electrical dysfunction. Mechanical and electrical dysfunction, and which will result in what is called inappropriate ventricular hypertrophy or dilatation. That's why we have to, more than one type of cardiomyopathy, either a dilated type or hypertrophic type or restrictive type. So the changes in the mechanical or electrical alterations or dysfunction affects the mechanical and electrical dysfunction that will result of the myocardium. Then it will result in a inappropriate ventricular hypertrophy or dilatation. Most of cardiomyopathies are due to genetic factors. And we have different classifications of the cardiomyopathy, but let's just stick with the top one, because the bottom one we are going to cover in the adult health 3, sorry. But the last one, it's not included or covered in the pathophysiology textbook. So which is the dysplasia type, but it's not that common, but at least it's it's one type of the cardiomyopathy. So in the pathophysiology course, we just focus on that 3 main types: the dilated cardiomyopathy, CMP, hypertrophic CMP, and restrictive CMP, and see what's the difference between dilated, hypertrophic, and restricted. So this figure explains very well the difference between dilated. So the A is the normal. It represents the normal heart. And then B, right here, and which is the dilated cardiomyopathy. Cardiomyopathy abbreviated as CMP, so dilated CMP. Now the heart is like a globular shape, and that's from dilatation. So you see how this is the left ventricle, how it's dilated, increase in terms of the room of the ventricle, the size of the chamber becomes large. So that's the largest circumference of the left ventricle. And you can see that it's not the apex or the base, but it's more of the both sides here. But anyways, but that dilated type is different than the hypertrophic type. Hypertrophy, so this is how I see the difference between the thickness of the myocardium wall or the myocardium, the muscle. Here it's normal size, but it's just the chamber is dilated, the ventricle is dilated. But with the hypertrophic type, the myocardium becomes thickened, so that's the thickness of the myocardium, which is the hypertrophy of the myocardium. So in the hypertrophic type, the wall of the left ventricle becomes thickened, so that's the thickness. It's not the size of the chamber. The atria now, because of this hypertrophy of the myocardium and the restricted feature of the contractility, which is now becomes the ventricle becomes very hard to contract because of that hypertrophy. Now, blood will have, there is a problem with the ejection and problem with the relaxation too, but mostly with the relaxation, which means that the problem with the filling phase, more blood will be stagnant and pooled in the left atrium, and that's why the left atrium will be hypertrophied, dilated, not hypertrophied, will be dilated. So the left atria may be dilated because of poor diastolic relaxation of the ventricle. Ventricle is supposed to be, relaxed in order to allow for the filling phase for blood to come from, to move from and flow from the left atria. But with the hypertrophy, more blood will stay in the left atria and able to be filled, or to move to the left ventricle. So that results in a dilatation of the left atria. And the restrictive type, which is D, the left ventricular cavity is of normal size. So the normal thickness of the wall, but the left atria is dilated because of the reduced diastolic compliance of the ventricle. The ventricle is stiff, is restricted, cannot contract well, enough or sufficient contraction. So that will result in, again, a dilatation also of the atria as well. So we have dilated cardiomyopathy, hypertrophy, and then restrictive type, or either you can call it restrictive or constrictive type. And this is from the mid-surg textbook, the difference between the hypertrophic type and dilated type. The hypertrophic type, the AGI textbook, the mid-surg textbook that we adopt or use for delta 2 and 3, it subclassify the hypertrophic under obstructed or non-obstructed. So this is just for information purposes. I'm not asking that this information, but at least just to know that we're trying to connect the patho and mid-surg. So because you will take the mid-surg and next spring. So the hypertrophic cardiomyopathy, CMP, either it's the non-constructive, obstructive, or obstructive type. So for now, let's just focus on the three main types: the dilated, hypertrophic, or constrictive or restrictive type. So dilated cardiomyopathy, we defined what is the dilatation, what is dilated cardiomyopathy. The left ventricle becomes extremely dilated, and the etiology here, these are the factors that could result in the dilated cardiomyopathy, the DCM: alcohol abuse, chemo, or infections affecting the heart, or inflammation and poor nutrition. The patient will have a significant decrease or decline in cardiac output. So the decreased cardiac output from the inadequate pumping of the heart, especially the left ventricle, it will result in or cause the patient to experience signs and symptoms or manifestations of decreased cardiac output, like dyspnea on exertion, DOE. DOE, dyspnea on exertion. Patient will experience the dyspnea, in response or with activity. Decreased exercise capacity, fatigue, generalized weakness, in addition to palpitations. The second type of cardiomyopathy is called hypertrophic, and we saw how it's dilated is different than the hypertrophic because the thickness of the muscle is has increased. So the hypertrophic cardiomyopathy, we said it's either obstructive or non-obstructive. About 50% of this type of the hypertrophic type, about 50% of patients, they develop this type of hypertrophic cardiomyopathy due to a genetic predisposition. So it is transmitted as a single gene autosomal dominant trait. So it has a genetic predisposition in about 50% of patients. And many athletes who die suddenly or with a sudden cardiac death, that's probably due to this type of cardiomyopathy, that they had hypertrophic cardiomyopathy, then resulted in a sudden cardiac death. That's most, or I mean not most, but at least if some of the athletes who die young age, or they die suddenly from with no history of cardiac or other diseases, they usually develop die from the hypertrophic cardiomyopathy. The restrictive type, the RCM, or you can call it constrictive or restrictive. It's not common as the other two types of cardiomyopathy, and it's characterized by the stiffness of the ventricles because of the restrictive or constrictive feature of the disease process, and the changes that affect the myocardium, which will result in restricting the filling of the left ventricle during the diastole. And patients will be presented in terms of symptoms. Patients will be exhibiting symptoms similar to the left or right heart failure, or both, as if they have heart failure signs or symptoms. So patients with RCM will be presented as if they have a heart failure. And the restrictive type, it can be primary or cause primary type, essential, or secondary to be caused by endocardial or myocardial disease. And the prognosis of this disease is very poor. There are other types of cardiomyopathy, but just let's stick with the three main types. I'm not required, I'm not asking even if you know about the dysplasia type, the last one, the arrhythmogenic right ventricular cardiomyopathy, because this one will be covered in Adult Health 3. So just know the dilated type, hypertrophic, and the restrictive type. Next topic, which is the valve problems, valvular dysfunctions. Valvular dysfunctions, the dysfunctions of that affects the cardiac valves, it can affect any valve. But we will cover only 4 conditions. 2 main valves will be covered. And each valve, either it's stenosis or regurgitation. So we'll cover the aortic and the mitral valve. The aortic valve Either it becomes stenosed, or there is changes to the valve leaflets which result in regurgitation. When we say regurgitation, it's same as insufficiency. Mitral insufficiency is the same as mitral regurgitation. Same thing for aortic insufficiency, you can say regurgitation. So valve stenosis, we have aortic stenosis and mitral stenosis, and under the valvular regurgitation, we have aortic regurgitation and mitral regurgitation. And here I have a description of what is stenosis and what is regurgitation. Now, I did not cover the prolapse. The prolapse is a step right before the regurgitation. But just to alleviate that confusion and just to eliminate the confusion at this point, or for the scope of this class, just to know the stenosis and regurgitation, I'm not requiring that you have to cover the prolapse, because we have a mitral valve prolapse and aortic valve prolapse, mostly with mitral valve more than the aortic. But the prolapse, again, is the step or phase that precedes the regurgitation. But I'm not asking that you know about the disease process, what's the definition and how to diagnose, or I'm not asking what the changes, the pathophysiological changes. So just let's focus on 01, the 01 to the stenosis and regurgitation only, but no prolapse. So the stenosis is the stiffness and thickening of the valve leaflets caused by calcification, calcium deposits, or scar tissue. When there is an inflammation and then the tissue becomes scarred, it becomes rigid and tough and thick. Or there is a loss of calcium deposited on the leaflets of the valve. That is called calcification. Either, one of these two cases, that could result in a stenosis of the valve. Regurgitation or insufficiency, which is the blood flow or leak backwards. So it's like a backwards of of blood is back up, like the blood. Suppose it's we'll discuss that and describe it for the aortic and mitral, how when it's regurgitate, there is regurgitation because the valve is incompetent, result in insufficiency or regurgitation. So there's backflow of blood to the to the opposite, like chamber. So the ventricle to aorta that can, so the regurgitation can include the ventricle to aorta, aorta to the left ventricle, pulmonic circulation to the right ventricle. So that's because of the incompetent or incomplete closure of the valve. So let's take a look at when the valve is normal structure of the valve is different when it's stenosed. So normal valve when it's open, and now when it's closed. And now this is when it's stenosed. Stenosed when it's open. See how it's supposed to be open like this, but it's stenosed. And this is when it's stenosed during the closure. See how it's different between the normal closure of the valve. So valvular stenosis and regurgitation. So let's take a look at the mitral valve, for example. Mitral valve supposed to open, to be wide open during the filling phase of the blood from left atria to left ventricle. So when the valve is stenosed, what happens? What would result when the valve is stenosed? So part of this discussion is called hemodynamics. Hemodynamics, which is the cycle of the blood pathway from ventricle to the blood vessels and to the lungs, and the circulation of the blood and the pressure within the ventricles and chambers and blood vessels. All of this is, and the measurement of this pressure in each of these blood vessels and heart or cardiac chambers is called hemodynamics. the study of all of this is called hemodynamics. So we also, again, we're going to visit this or cover it extensively in the adult health 3. So the hemodynamics, so the valve stenosis or regurgitation affects the hemodynamics of the myocardium, of the heart and the cardiac cycle. Now, the mitral valve, it's stenosed, which means during the filling phase, which is during the diastole or the filling phase of the ventricle, right, which is the ventricular diastole, the mitral valve is supposed to be wide open. However, when it's stenosed, then less blood is going to be to pass through that small orifice or stenosed valve, and that will result in less blood coming into the left ventricle, and more blood will be stagnant and pooled in the left atria. Pressure will rise in the left atria. Pressure will rise in the pulmonary veins. Pressure will rise in the lungs, and in the next to that will be increased pressure in the pulmonary artery, and then on the right side of the heart. So that is called the hemodynamics. So the so that's the mitral valve stenosis, and then mitral valve regurgitation. That's when during the systole, ventricular systole, when the left ventricle is supposed to contract and eject blood through the systemic circulation, through the aortic valve to the systemic circulation, then the mitral valve is supposed to be closed or open. Mitral valve is supposed to be
during what? During what?
During the systole, ventricular systole.
It's supposed to be open, right?
No, it's during the ventricular systole, during contraction of the left ventricle to eject blood through the aortic valve. The mitral valve is supposed to be completely closed 100%, which means otherwise, if it's incomplete with, it doesn't complete fully closed, then some blood will back up to the left atria, and that is called the incompetent valve. Some of the leaflets are not strong enough and weak, and that will result in backing up, blood to back up to the left atria, and that's regurgitation. Mitral valve regurgitation, blood being, backed up to the left atria because the valve is supposed to be closed, but it's incompetent. So that result, which causes insufficiency or regurgitation. So that's the difference between mitral stenosis versus mitral valve regurgitation. Aortic stenosis and aortic regurgitation is the same concept. Stenosis versus regurgitation. Stenosis, that's for the aortic valve, that's when the orifice is narrow and obstructing the left ventricle outflow during the systole. So when we say systole here, is it the ventricular or the atrial systole? Ventricles. Has to be the ventricle, right? Because when the blood being ejected from the left ventricle to the systemic circulation, the aortic valve is supposed to be wide open, right? Wide open to allow blood to be ejected from left ventricle to the systemic circulation, and the mitral valve completely closed. So if the aortic valve is stenosed, which means that there is a decreased there is stiffness of the valve leaflets, and it's not open, wide open, then it will result in decreased amount of blood being ejected to the systemic circulation. So it's not allowing all the blood to be ejected from the left ventricle to the systemic circulation. That is what I said here, obstructs the left ventricle outflow during the systole. Systole, which is the contraction of the left ventricle. And that will result in the hypertrophy, because the left ventricle, that's over time, which is long-term complication from the aortic stenosis, that will result in left ventricular hypertrophy, because the left ventricle will attempt to compensate with that stenosed valve, with increase the effort over time, will result to push that blood against the small orifice, and that will result in the hypertrophy of the left ventricle. The patients with aortic stenosis develop that either due to genetic disease or rheumatic fever, and we'll cover that towards the end of the lecture about rheumatic fever, or atherosclerosis. Patients presented or the symptoms begin when the cardiac output, remember that decreased amount of blood ejected from the left ventricle through the small orifice aortic valve result in decreased cardiac output. So the symptoms begin when the cardiac output becomes unable to increase to meet the body requirements during the exertion. So the patient will have or will exhibit the dyspnea and exertion, angina, chest pain, and they may develop also a syncope or syncopal attack, or what is called the fainting. They faint because of the decreased cardiac, significant decrease in cardiac output. And fatigue and peripheral cyanosis and all that has to do with the decreased cardiac output. So this is the sequel of events, what is called the hemodynamics of the aortic stenosis. LV failure results in LA, left atrial pressure will rise. Why? Can anyone explain why the LV failure results in increased pressure in the atria, left atria? The left ventricular failure result lead to, yeah, go ahead.
It will result in pressure in the atria because it's not pumping the blood out, so the blood is backing up to the atria, right?
Actually, it's not backing up. This is aortic stenosis. There's no backup of blood in the atria, but the hemodynamics means any pressure in one chamber, it will affect the adjacent chamber, which means that the less blood ejected from the left ventricle through a small orifice from the aortic valve stenos. So more blood stagnant, right, retained in the left ventricle. More blood here, more pressure, hypertrophic, and more pressure in the left ventricle. Then that pressure will be transmitted to the left atria. Not because of the blood going to move or to be to back up to the left atria, but because the pressure has there is a rise of pressure on the left ventricle, then the pressure will also be transmitted. The pressure, not the blood, will be transmitted to the left atria. So the left atria will dilate, and then that result in pulmonary artery pressure will rise, which is the hemodynamics that I just described earlier about the pressure goes, it's like a vicious cycle. One chamber affects the other chamber, and then pulmonary veins, and then lungs, and then pulmonary artery. So that's eventually result in a right ventricular hypertrophy and the pulmonary congestion. And eventually, patient will have right heart failure. So patients with aortic stenosis, they would have a pulse pressure problem. So aortic stenosis is different from aortic regurgitation. Stenosis of the aortic valve will result in a narrow pulse pressure. So systolic, extremely high, diastolic, very low. Both the systolic and diastolic will be increased. The difference between them will be less than 40. The difference between systolic and diastolic in patients with aortic stenosis will be less than 40, because the normal pulse pressure is about around number 40. So it'll be less than 40. That's a narrow pulse pressure. On the other side, patients with aortic regurgitation, they will be exhibited with a wide pulse pressure. So the pulse pressure in patients with aortic regurgitation will exceed the 40. So the hallmarks, manifestations of patients with aortic stenosis will be the syncope, chest pain, the angina, and the eventual long-term heart failure. These are the three things that will be included as hallmark manifestations of aortic stenosis. Aortic regurgitation in which that the aortic valve becomes incompetent, which is called insufficiency of the aortic valve. So it will allow, which obviously here is that the aortic valve during the diastole, which is the filling phase, relaxation phase of the ventricle or the cardiac cycle, that the ventricle the aortic valve is supposed to be closed, but during the filling phase, while the blood is being filled from the left atria into the left ventricle through the mitral valve, which is wide open. However, during this diastolic phase or the relaxation phase, the aortic valve is not completely closed. There is incompetency or insufficiency, or there is some backup of blood is coming from the systemic circulation back into the left atria due to that incompetent aortic valve. That is called regurgitation, aortic regurgitation. So it allows regurgitation of blood from the aorta back into the left ventricle during the diastole, or what is called the relaxation phase or the diastolic phase. The left ventricle will, eventually will dilate and result in the hypertrophy of the left ventricle, because it will attempt to compensate with that increased blood volume backed up from the systemic circulation into the left ventricle. The patients who develop the aortic regurgitation due to the infective endocarditis or congenital disease or hypertension, and the patients, for the most part, will be asymptomatic, no symptoms for many years. And then they will develop the left ventricular failure and signs and symptoms of LV failure. They would have bounding arterial pulse, and the pulse pressure would be wide, not like stenosis, narrow pulse pressure. And mitral stenosis, we did, I went over that, but here's the more description of etiologies and hemodynamics, or the sequelative events with the hemodynamics of mitral stenosis and mitral regurgitation. So mitral stenosis, see how is the mitral valve becomes, have that kind of fish mouth orifice when it's stenosed. And mitral valve stenosis, we said that takes place during the, or more like, significant during the diastolic phase of the left ventricle. Supposed to be wide open during the filling phase, diastole, but it's stenosed. So this blood will get through to the left ventricle, and patients who would develop this due to the rheumatic fever, that's the most common cause. Atrial myxoma, which is a tumor, affects the atria. Calcifications, calcium accumulation, or thrombus formation, which will affect the valve leaflets itself. Blood clot that will form on the mitral valve leaflets. And then here, the sequelative events, the hemodynamics we just described earlier about the left ventricle, the left atria, the valve opening narrow and prevent blood from left atria to left ventricle. That's during the ventricular diastole. Result in left atria pressure will rise because the pressure will be stagnant. More blood stayed in the left atria. Left atria, due to that large amount of blood in the left atria, it will dilate. Pressure will increase eventually from left atria, transmitted to the pulmonary veins, and then back to the lungs, and then to the pulmonary artery. Pressure also will rise. And then that will, that again said, this like a vicious cycle goes back to the hemodynamics, which is the right ventricle will hypertrophy, and then pulmonary congestion, and then heart failure, and that results in significant decrease in preload and cardiac output. The mitral regurgitation, and that's results from the fibrotic or calcified calcifications or calcified changes that would prevent the mitral valve from closing completely during the systole. So there's an incomplete closure of the mitral valve during the systole, because during the systole, the left ventricle is supposed to eject blood through the aortic valve, and the mitral valve is supposed to be completely closed. Incomplete closure of the mitral valve during the left ventricle systole result in blood backed up to the back up to the left atria, and that will result in more blood retained in the left atria, more pressure, and results in hypertrophy of both left atria and left ventricle. The etiologies, we said rheumatic heart disease. That's the most common, most predominant cause of the mitral regurgitation. Ischemic heart disease, infective endocarditis, and could also result as a congenital anomaly. Patient will be similar to the mitral stenosis, that they also could have that mitral regurgitation and be asymptomatic for many years, for decades, until they will have a significant decline in cardiac output, and that will result in fatigue and general weakness and dyspnea and exertion or orthopnea. And the patients with mitral valve insufficiency, they tend to develop the AFib. So the AFib, it's AFib as an A, which is atrial fibrillation, and I will cover briefly the dysrhythmia called atrial fibrillation, AFib. It's presented in about 75% of patients with mitral valve regurgitation. Acute traumatic fever and rheumatic heart disease. Yeah, the disease, this disease can lend itself or can be covered in the PEDS course, because it affects the, people are young age as children. So it will have more coverage on, on this disease in the PEDS OB or PEDS course. So the rheumatic fever, which is a diffuse inflammatory disease caused by delayed immune response to infection by the specific group, the bacteria called A beta hemolytic streptococci. So usually this disease presents in about like people in their between like 5 to 15 years old, after they had that specific infection with the group A streptococci infection. And the patient will have specific manifestations, like inflammation of the joints, skin changes, in addition to nervous system manifestations and cardiac manifestations as well. So if untreated, rheumatic fever causes rheumatic heart disease. So the patient eventually will develop a valvular heart problem, valve complications or valve dysfunctions. So they develop a skin rash, specific types of skin rash called erythema. They have also a generalized weakness, joint pain or joint disease, and the lab values will reflect the elevation of the ESR, erythrocyte sedimentation rate, changes in the EKG or ECG, arthralgia, which is the joint pain, arthralgia, joint pain, fever as well. So this figure explains very well the pathophysiology of the rheumatic heart disease. So the pathogenesis of the structural alterations of the acute rheumatic heart disease begins when the patient developed at young age, between 5 and 15 years old, develop what is called the upper respiratory tract, but it has to be caused by specific type of bacteria called A beta hemolytic streptococci or streptococcus. So this specific bacteria, they believe, it's believed that the scientific, basis of this is that they suspect this as a hypersensitivity reaction or response. And it says here that it is proposed that the antibodies directed against the M proteins of certain strains of streptococci. So, which means that the streptococci will attack the inflammatory process, will attack the valve leaflets and results in inflammation. That inflammation, eventually the healing process, results in fibrosis. And the fibrotic tissue or fibrosis then makes the valve leaflets dysfunctional, and that results in what is called valvular dysfunctions or deformities. So again, I said that more of this discussion, or in depth, I would say, discussion that will be covered in the PEDS course. Infective endocarditis, which is the inflammation of the endocardium, the inner layer or lining of the heart. So it can be caused by the bacteria, viruses, or other microorganisms. It's blood-borne microorganism adherence. So patient may develop this from let's say UTI and then become septic or septicemia or any other blood infections. And then that same bacteria from the blood, it will travel to the heart and cause this disease. Bacterial endocarditis of the mitral valve. The endocarditis, there's something called vegetation and the endocarditis. The vegetation, which is the lesions, which is a mass of platelet, fibrin, microorganisms, and the inflammatory cells. All of these are going to form deposits, what is called the vegetations vegetations in the disease process called endocarditis. So this vegetation is or develop as lesions composed of a mass of platelets, fibrin, microorganisms, and the inflammatory cells. And this will be deposited on the leaflets of the valves and result in valve dysfunctions. Next topic is the heart failure. CHF, we say heart failure because some of these heart failure types or some types of heart failure is not, doesn't involve the congestion as one of the features or the mechanisms within the disease process. So we just say heart failure because we have too many types of heart failure. Some are congestive, others are non-congestive. So the heart failure, which is a general term used to describe several types of cardiac dysfunction that will result in inadequate perfusion of tissues within blood-borne nutrients. The etiology of the disease, patient may develop this due to long-standing hypertension, undiagnosed hypertension, valve dysfunction, like mitral valve, aortic valve dysfunction, acute or chronic. Acute MI, pulmonary embolism, cardiomyopathy, endocarditis. All of these are, in addition to the other risk factors listed on this slide, but the most common causes, the ones I just described: the valve dysfunctions, acute MI, chronic or acute. I'm sorry, the MI, acute or chronic, the hypertension, anemia, pulmonary embolism, and cardiomyopathy. The endocarditis as well. I want to add two more things to the heart failure, because we're going to classify it as left heart failure, right heart failure, high output heart failure. So these are the etiologies and causes that cover all the different types of heart failure. So because I will add two more causes and etiologies. One of them is the thyrotoxicoses. Go back to the endocrine system. You'll find thyrotoxicoses, which is the elevation of T3 and T4, and that's in a hyperthyroid disease, right? That's when the patient with hyperthyroid develop the thyrotoxicoses or thyroid storm. That is a risk factor or an etiology for the heart failure. The other one, which is fever, and then I will add another one, which is the anemia, severe chronic anemia. Now, the fever, severe chronic anemia, and thyrotoxicoses or hyperthyroidism will cause or result in a heart failure, and the classification of that would be high output heart failure, because of the hyperdynamic state of the disease process of thyrotoxicoses or the fever or the hyperthermia or the severe, chronic anemia that will result in hyperdynamic state, and then patient eventually will develop the high output heart failure. The initial phase of the high output heart failure, there is an increased cardiac output, but eventually the heart cannot maintain, the compensatory mechanism. To maintain the cardiac output to be increased, so it will eventually fail because they consist, persistent and increased performance of the heart to compensate for the, either one of the diseases, the fever or the anemia or the thyrotoxicosis, because the hyperdynamic state. So the heart eventually will fail. The initial phase will be there is an increased cardiac output, but eventually the heart will fail because the heart cannot maintain that increased demand of the hyperdynamic state or the hypermetabolism, and the demand for the oxygen and the oxygen demand that is going to be sustained. So that's why the heart cannot be unable to maintain that, so eventually will fail. So that is called high output heart failure. And we have right side and we have left side heart failure. So the left side heart failure. So the heart, first of all, the heart failure is caused by systemic hypertension in about 75% of cases. Almost like 2/3 of patients with heart failure, they develop this heart failure from hypertension, systemic hypertension. And another 1/3 of the patients who would develop that, about 1/3 of the clients will experience who develop the heart failure, the heart failure will be like a complication from the acute MI. So about 1/3 of the clients experiencing myocardial infarction also develop heart failure. So left side versus right side. There are different classifications of heart failure. One of them is left-sided heart or left-sided heart failure, like left side, right side, high output. And I just explained what is the high output heart failure. Another cause of the heart failure is the septicemia, the high output. So the high output can result from hyperthyroidism, which is thyrotoxicosis, or from anemia, fever, septicemia. And because of the inability of the heart to supply the blood with blood-borne nutrients, despite adequate blood volume and normal or elevated myocardial contractility. So eventually the heart will fail because of the high demand for oxygen and nutrients. So the left versus right side. The causes of chronic heart failure in general, we said hypertension, ischemia, valve dysfunction, like aortic stenosis, for example. Alcohol abuse could also result in a heart failure. Cocaine abuse, in addition to all the factors that we included or mentioned earlier. So the left versus right heart failure. Remember, did you cover this in the adult health one? Like the heart failure and the different types?
Yes, Professor, we did. We previously just had that information on our last exam with Gagnon.
Did you go over the pathophysiology or just manifestations and signs and symptoms and nursing care? Or?
Yeah, we just went over the signs and symptoms, not the pathophysiology.
Okay, so let's focus on the pathophysiology then. Yeah, good. Thank you. Perfect. So that's, I'm not going, to cover the manifestations and management or I mean, the signs and symptoms. So let's just focus on the pathophysiology and the resultant complications from that. So the pathophysiology of ventricular, so when we say heart failure, we focus more on the ventricles. So we say ventricular failure. So it's either say systolic or diastolic. So systolic dysfunction versus diastolic dysfunction. Systolic dysfunction, which is low cardiac output caused by impaired systolic function, which would result in a decreased ejection fraction. And last week, I believe that we went over the equation, how to calculate the ejection fraction from the stroke volume, right? And the left ventricular end diastolic volume times 100. So we know the equation. So the ejection fraction is supposed to be between 50 or 55 up to 70%. Patients with systolic dysfunction, they tend to develop or have a lower ejection fraction than 50. So it will be less than 40%. Most common cause of CHF is systolic failure. The left ventricle will lose its ability to generate enough pressure to eject blood forward, which means to that systemic circulation through the aortic valve. So the heart is unable to generate adequate cardiac output to perfuse tissues. So that's the hallmark of, when it comes to systolic failure. Always remember that ejection fraction less than 40. Diastolic, in which that there's an increased diastolic filling pressure, which is during the relaxation phase, the filling phase. And that is result or caused by the impaired diastolic relaxation and decreased ventricular compliance. When we say ventricular compliance, means ventricular relaxation. The ventricle is supposed to be completely relaxed to fill the blood, to allow blood to be filled from the left atria. Patients with diastolic failure, they tend to maintain or preserve the ejection fraction over 40. Will be between like 40 to 50, but it doesn't significantly affect the ejection fraction with systolic failure, like diastolic failure, like systolic one. Systolic, they have ejection fraction less than 40, but with diastolic, they tend to preserve a higher level of ejection fraction than patients with systolic. Like their ejection fraction would be over 40, up to 50, but not higher than 50, because the normal ejection fraction is 50 or 55 up to 70 or 75. There are other types of the heart failure, but these are the most common ones, and let's just stick with these. Systolic, diastolic, right, left, and then the high output heart failure. So the diastolic, the last thing about diastolic failure is that usually there is the result of left ventricular hypertrophy, result from the LV hypertrophy, and pulmonary congestion. Compensatory mechanisms: sympathetic nervous system stimulation, epi, norepi, release, RAS system activation, and other neurohormonal responses like the BMP, which is the hallmark of the blood level that will be elevated during the acute phase of the disease process. So when the patients are admitted with the decompensated CHF or heart failure to the hospital, the first thing we will draw blood level is the BMP. And the BMP usually it's between 0 to 100 nanograms. And any number over 100 should indicate, that a patient has in decompensated phase of the disease process. But there are like different, there is some parameters for that, which means how we interpret or do the interpretation for the BMP results. There is specific like table that with high likely, less likely, and it's different than like normal or abnormal or reference ranges. But the BMP normal is 0 to 100. Antidiuretic hormone, the ADH hormone, and the endothelin will be also elevated because that's vasoconstrictive. So right side versus left side. Again, I'm not going to cover the manifestations because you just covered and did that or had it done in adult health 1. So let's just move on. And we have the complications will be pleural effusion. Patients with heart failure, we always make sure that we haven't developed the pulmonary edema or pleural effusion or dysrhythmia or blood clot or thrombus in the left ventricle or hepatomegaly. So these are the signs we're trying, as we assess the patient and to identify or find out if they have developed any of these complications. But long-standing and long-term, they tend to develop, at least one or more than one of these complications. Dysrhythmias. Dysrhythmias, what is the best term to use? Dysrhythmia or arrhythmia? I've seen professionals saying arrhythmia. Dysrhythmia, right? Dysrhythmia means abnormal rhythm. But arrhythmia means there is no rhythm, the absence of the rhythm. So abnormal rhythm means dysrhythmia. So there is a disturbance of the heart rhythm. The I'm going just to cover just the very basic pathophysiology of just for the dysrhythmia as a basic foundation, or to set the stage for adult health 2 and adult health 3, because we're going to revisit that and cover all the different types of dysrhythmias in adult health 2, mid-surge 2, and then the advanced EKG or ECG in the adult health 3. So there's a lot of room, a long way to go in terms of coverage for the dysrhythmia. Just in this course, we will cover the very basic pathophysiology of the dysrhythmia. So the dysrhythmia can be, an example of that would be like tachycardia, flutter or fibrillation, brady or bradycardia, premature ventricular contraction, PVC, or PAC, premature atrial contraction or asystole. These are there are also what is called life-threatening dysrhythmias, like ventricular fibrillation, ventricular tachycardia. So the VTAC and VFib, and so all of this will be covered in, the interpretation of the EKG strips will be done in adult health 2 and advanced in adult health 3. So the main causes why patients develop the dysrhythmia. First of all, we said we will say dysrhythmia, not the arrhythmia, because arrhythmia means the absence of the rhythm. But dysrhythmia is the presence. There is a rhythm, but the rhythm is not normal or abnormal, albeit it's disturbed. So causes patients develop dysrhythmia due to a disturbance in the relationship between electrical conductivity and the mechanical response of the myocardium, which means that the conduction system begins or starts from the SE node, the natural, we call it the natural pacemaker. This is our natural pacemaker. We don't need a pacemaker because our SE node is working. When it's not doing the job or it's dysfunctional, then people will have implanted a pacemaker. The pacemaker will be implanted to replace the SE node or to work with the SE node. Depends, that's synchronous or asynchronous pacemaker. But the SE node is a intrinsic natural pacemaker. It's going to elicit or fire the impulse. Natural, spontaneous, continuous. So the SE node fires the impulse, innervates the atria, and then the impulse will reach the AV node and then to the bundle of His, the Purkinje fibers. So that's the conduction system. That's the normal conduction system. So the impulse fired from the SE node is supposed to be transmitted normally with some delay, natural delay at the AV node, and then to the innervate the ventricles. So that's the electrical activity of the myocardium, of the conduction system. Then the mechanical aspect or the mechanical function will follow, which is the atrial contraction and then the ventricular contraction. If there is no electrical activity, there is no resultant mechanical activity. So when there is a disturbance in the relationship between the electrical conductivity and the mechanical response of the myocardium, then you anticipate a dysrhythmia, or dysrhythmia will result from a disturbance in the impulse formation, which means the SE node is not firing the impulse. Or the impulse has been fired from a cell outside of the conduction system, came from any cell in the myocardium, not from the SE node or the AV node so it came from what is called anything outside the normal system. We call it ectopic foci. Ectopic, which is ECTOPIC, ectopic or ectopic. So ectopic foci means the cell outside of the conduction system, which is abnormal. But this cell is able to fire the impulse. We call it, so it's called ectopic foci. Now, the features that are special for, only present in or characteristics that only apply to the cardiac muscle and cells in the myocardium. These are the the characteristics. automaticity, which means pacing function. Automaticity means pacing function, means that any cell in the myocardium can and is able to pace the heart, which means pacing means eliciting or firing the impulse to do the conduction system, or to fire the impulse, and can result in some type of disturbed contraction if there is any but it will be presented as a abnormal rhythm, which is dysrhythmia. So any cell in the myocardium can, if it fires the impulse, it's called ectopic foci because of that function. This is, cardiac muscles, and the cells in the cardiac muscle. Any cell has this ability, which is to pace the heart and to fire the impulse. Excitability, conductivity, and contractility. That these are the manifestation. The characteristics of the cardiac electrophysiology. So, and they are, pertinent just to the cardiac muscle. Now, the okay, so the ectopic foci, when the ectopic foci, which is the abnormal cell outside of the normal conduction system, fires the impulse, it results in a dysrhythmia. So if there is a disturbance in the impulse formation, the impulse didn't come from the SE node or the AV node or the Purkinje fibers, it came from ectopic foci. Or if there is a disturbance in the impulse conduction, means there is a delay or there is a block. If the delay exceeds a normal delay at the AV node, the impulse stayed longer in the AV node before, being transmitted down to the His or Purkinje fibers. Or if there is a complete blockage, the impulse stayed right there at the AV node. So any of the three scenarios that will result in dysrhythmias. So dysrhythmia could result from myocardial ischemia, infarction, MI, electrolyte imbalances like hypokalemia, hyperkalemia, and other electrolyte imbalances other than just the potassium, decreased oxygenation, hypoxia, drug toxicity, certain indications, drugs, when it reaches the toxic level, it results in or leads to dysrhythmias. These are some of some types or classifications of the dysrhythmias. Classifications are either Brady dysrhythmias or tachydysrhythmias, like sinus tachycardia. That's tachydysrhythmia. Sinus bradycardia is a bradydysrhythmia. VTAC, VFib, other dysrhythmias would be like repetitive rhythms like bigeminy, trigeminy, like when you have like two PVCs or three PVCs running next to each other, in which it's it's repeated like rhythm, the same dysrhythmia is being repeated one after the other. Premature complex. So I'm not asking that all of these, but just at least just to know the basic pathophysiology, which is the causes, etiologies, the normal conduction system, where the origin of the impulse from the SE node, which is basic EMP concept, and then the all of this will be covered in Adelphi 3 and 2 and 3, which is the so this is just, I provided this just for illustration purposes, just to show you that the EKG, when we do the EKG or ECG, it's like the analogy for this, like a camera, you're looking at the heart from different angles, and each angle will provide you with one lead, because we have 12 lead EKG. And in tele, people who work in tele probably know this, that because we have a running lead, continuous EKG with one lead EKG, we use one, the best lead to be used is lead 2, which is lead 2, which is lead 1 runs from right arm to left arm, lead 2 from the right arm to left foot, and then this is lead 3. So this is the lead that is the will provide us with the more, the clear P, QRS, complex, and T wave. It's the best lead to be used as a running lead as lead 2, or other some places they use something called MCL1, like modified chest lead 1. So we have chest leads and we have peripheral leads. All of this will be covered in adult health 2 and 3 again. So don't get scared from the EKG, but all of this will be covered in the mid-surg courses. All my expectations that you understand the basic pathophysiology of the EKG or dysrhythmias, why patients develop dysrhythmias. These are just methods how we measure the PR interval and the QRS, and we know the norm. So what's the normal ranges for the PR interval and for the QRS complex or interval. And the last 10 minutes, we'll try to cover the shock, because that's the last content area in today's lecture. So shock, which is a complication, or you can call it also a disease that would result from different conditions or different diseases or different disease processes, and eventually patients will have a problem with so the cardiovascular system will eventually fail to perfuse the tissue adequately. So the cardiovascular system, because of the changes that happen due to the certain previous, so proceeding what precedes the cardiovascular system failure is other processes, diseases, conditions. So for example, cardiogenic shock, for example, patients who develop the cardiogenic shock, they will have problem with that the myocardium won't be able to eject blood or perfuse or send blood to the systemic circulation to perfuse the tissues. So there is significant decrease in the amount of blood ejected from the left ventricle with the cardiogenic shock. Who would develop this, for example, is the patient with acute myocardial infarction. They will develop the cardiogenic shock. And then hypovolemic shock, who would develop hypovolemic shock from the significant decrease in blood volume, which would result in decreased filling phase, or the blood return to the right atria. So less blood's return to the right atria because the hypovolemia. Who would develop that? Patient with the different there are different reasons why patients develop the hypovolemia. And conditions that would result or lead to hypovolemia is, what would you put under the hypovolemia in terms of etiologies or conditions that would result in hypovolemia? Who would develop hypovolemia and eventually hypovolemic shock?
Someone that has low sodium.
Yeah, hyponatremia and then fluid loss, right? Fluid loss, and then the hemorrhage, bleeding. So massive bleeding or long standing, like GI bleeding, for example, that could result in hypovolemia. Motor vehicle accident or trauma resulted in bleeding. Diuresis, patients losing large amount of fluids. Diabetes insipidus, patient will lose large amount of fluids with diabetes insipidus, DI. So this slide shows the difference between hypovolemic, cardiogenic, septic, and neurogenic shock. In terms of 4 different parameters, the first one is the preload, which is the blood return to the right atria, measured as what is called the CVP, central venous pressure. The central venous pressure. So all the three or the four parameters, CVP, cardiac output, systemic vascular resistance, and the SVO2, oxygenation in the veins, all the four, all these four parameters, they are there are significant parameters in the ICU setting, and we have measures or tools and devices to measure these parameters. So we have a central line or central CVP line, for example, to measure the CVP pressure, which is central venous pressure. Cardiac output, same thing that we measure also with the E line or arterial line. And same thing with the SVR and the SVO2. So the CVP measures the preload blood return to the right atria. Cardiac output, we know what is the cardiac output. It measures the pumping ability of the myocardium. And then the SVR, which is the resistance in the vascular system. So it measures the afterload, the resistance, the afterload in the vascular system. And then the tissue perfusion will be measured by the SVO2. So the patients with hypovolemic shock didn't have enough fluids, blood, so that will result in a decreased preload, insufficient blood return to the right atria. Cardiac output, eventually that would, less blood to the right atria, coming to the right atria, less blood will be ejected from the left ventricle. So decreased cardiac output. The SVR will be increased because of the vasoconstriction. Hypovolemia, patient would have vasoconstriction. So the perfusion to the tissues will be decreased because of the hypovolemia. Cardiogenic shock, they will have an increased CVP, decreased cardiac output, increased SVR, decreased tissue perfusion. It may, sound like a complicated or confusing, but you have to really go into the pathophysiology of each type of the four different types of shock to figure out why the CVP and cardiac output and SVR and SVO2 would be altered, either increased or decreased. So I think we have only 3 minutes left. Yeah, the last one here, MODS is not required. So I'm not requiring that, about the MODS, because we will cover that anyways in the adult health 3 under the MODS and the SIRS, and septicemia and sepsis will be covered. I will cover that as well in terms of pathophysiology. So I will post answers for the case studies on the Blackboard. And about the shock, just know the pathophysiology of each type of the 4 different types of shock. And next time, if you have any question about the shock, if you don't understand, the pathophysiology of the 4 different types of shock, and I will go over it. It's just because of time, we don't have enough time to go over the specifics about the 4 different types of shock. So I will stop recording.